Okay, now this section, this is a little bit intense, I want to tell you that. But I think it's important to talk about the system's life cycle. I mentioned already all nurses, healthcare professionals need to know have some information technology competencies. Now, since you have implemented, you're on your at least second generation of systems, you probably have seen those people depart that say, I'm retiring before this system hits my practice. I'm getting out of here before, I'm retiring before that. So those people are gone, we hope. Or maybe they were at Mountain State and they moved to Walmart, I don't know, or vice versa. Or they're trying to move until the system catches them. Okay, so now we need nurses that know the environment, know the workflow, to help implement systems. And now we're talking about things like optimizing. So you have the systems already, how can we make them better? And you know, I gave you the example of my veterinarian who has a system, he doesn't even use it to the fullest extent. So that happens as well, that we might have reports, we might have things that we can utilize, we might have data we can utilize, making information that we maybe don't even know about. So that's why we need nurses and healthcare professionals. We can identify errors, that too, but areas that need improvement that might use health IT, but we have to understand some of these concepts. When I first moved to Vanderbilt, one of my, they knew that I was in the information technology department, teaching nurses about informatics. They have a master's degree program there just for nursing informatics. And our students were precepted. The students were from all over the country, so they were precepted all over the country. We had contracts all over the country. The students also needed certain things, immunizations, chest x-ray, things like that, so that all had to be documented. Well, I went into the department that was in charge of that. I even forgot what the name was. But we went into the department and they had piles of paper, stacks of paper all over the place. And this woman was like, we need you to come and get us an information system to help with all these piles of paper. And she said, I'm doing my budget now. Tell me how much I should put in the budget for a system for my department. And I refused to do it. I said, I'm not doing this because I don't know what your needs are. We have to start with the needs. We have to look at what you have now versus what you think you want. We have to look at the software that's out there. Do we design our software? Do we buy software that's already out there? So this person was not aware of the system's life cycle. So that's why I'm going to be talking about that. And some of it you may think, why am I learning about this? But hopefully someday you'll be able to think back on some of these concepts. When I was talking to this person from the Collaborating Center in Maryland, she said that her degree in informatics came in very handy. And one of the things she did along the way too was not only coordinate the care of the patients, but she was implementing some new software in their organization. And this company was new. They were essentially the first customers of this company. So because she knew informatics concepts, she knew how to communicate with them, and she knew that things happen in a certain order and things take time. And remember, I related to you that when I had my first job in healthcare IT, I thought it was 2-year job, put the system in, go on to the next thing. No, it can be a lifetime job because we're always improving. Maybe someday we'll be more interoperable, we'll have systems that are more intuitive, we'll get the data we need, et cetera, et cetera. So that's one of the reasons why we're talking about this. Oh, back to my little scenario and how I refused to give this person a number because I had no idea what she needed. After we got a systems analyst involved, and this was at Vanderbilt, we borrowed a systems analyst probably over a year. We had bi-weekly meetings to talk about this. In the end, we only implemented a system for part of the functions, and it was for document management. It was sending all these pieces of paper around, these chest x-rays and the immunization results, et cetera. Just the document management alone cost like $60,000. And so I said to her, well, how much did you put into your budget way back when? $7,000. So $7,000 would have been like nothing. So she should have attended this class. So I'm going to quickly go through some of these things, see if you can think back if you were involved in any kind of implementation. Maybe did you do things right? Could things have been better? And here are some of the concepts that I will just very quickly go through. Now, depending on whose book you use, and this comes from Kendall and Kendall, which is one of the references that I listed here, I'm pretty sure. Yeah, Kendall and Kendall is a reference for systems analysis and design. And a lot of us could be termed as being the analyst. We analyze what the current practice is, what the current workflow is, and what do we do with that. Okay, so the systems design lifecycle, I've also seen it called the systems development lifecycle. As it says here, it's a process for developing information systems in a deliberate, structured, and methodical manner. The project lifecycle of a system implementation can also be described using this framework. So it's planning, analysis, design, implementation, and evaluation. Now I'll ask the nurses, have you heard these words before? Planning, analysis, design, implementation, evaluation. Have you heard them together as a package? I feel the vibes here. Nursing process. Nursing process. So as soon as I realized, when my first job was in healthcare IT, I didn't know nothing about healthcare IT. When I realized it's really like the nursing process, then I'm like, I can do this. I understand this. I understand these steps. Okay, so think of the nursing process. Nursing process is a scientific method. This is a scientific method. It can be, okay, so maybe your organization has asked for volunteers to evaluate the need for an information system replacement. What do you have in your practices, by the way? What's your main? All scripts? Okay. Is that what everybody has?
No, we have Epic.
Epic, okay. Are the all scripts persons going to Epic? Or do you know? Might be good to know. Job security, as I said. Okay. So, because you can apply some of these techniques. So what are the steps? Where do you start? You document where you are now, where you want to go, how to get there. So this is a methodology used to describe the process for building information systems, intended to develop the information systems in a very deliberate, structured, and methodical way, reiterating each stage of the life cycle. Okay, so I'll talk about each of these steps. So planning happens early on. That's the first phase. So a plan has to be made identifying what are the goals, what are the goals of implementation, what is the scope, and we often talk about something that could be called scope creep, where you think you're building a 10-story building, and by the time everyone gets in the requirements and their wish list, then you find out, oh, it's really a 15-story building. Well, you have to have the framework for this, whatever building you're building early on. So you want to know, okay, we are implementing secure texting in ambulatory. That could be the scope. Maybe then when somebody starts to say, oh, but what about this, and what about this, and what about this, then that's the scope creep part. We don't want to do that. We just want to have a defined scope. We want to engage the stakeholders. So everyone in this room is a stakeholder. You're a stakeholder because you're an employee. You're a stakeholder because you're a patient as well. We identify required functionality, and that means what do we want the system to do. And we evaluate the cost and the benefit. Sometimes we forget this evaluation stage, just like in nursing. Sometimes we forget the evaluation. Oh, we're too busy, we don't have time, we kind of cut this off and forget the evaluation stage, and that's not good. That's not a good thing. All right, so in the planning stage, and this, the left-hand side is sort of if you're developing systems, which probably you're not. I mean, Years ago, we did develop, Vanderbilt developed their own information system, which now you might know they're changing over to Epic, by the way. But for years, they had their own homegrown developed system. Okay, so you think of things like, well, what do the end users, the customers, need out of the system? Do they need things like improved shift reporting? Who are the key players in the success of the system? So these are some of the things we think about. Who are the stakeholders? We talked about that. It has to be aligned with the strategic goals of the organization. So in implementing a system, you have to be aware of what is the mission of the foundation. What is our mission? I'm sure some people have business cards with the mission on the back of it. Where do you find your mission for your organizations? There's a mission there somewhere, high level. Mission. Could be something like to provide safe, effective care for our patients. It could be something very succinct like that. Might be interested in figuring out what the mission is. If it's a Catholic facility, you know, it adds other words to there. You know, the mission might be related to, you know, something Catholic. My husband's Catholic. I should have asked him for an example. Okay, so again, you need to be aligned with where the organization is going. Is your organization growing? Is it staying the same? Are you merging with other organizations? Are you collaborating with other organizations? All those things need to be assessed, including the business case for why are you doing this. And that the business case is probably something formal, written. You look at all feasible approaches and you look at options, because there's usually always options. Okay, so here's just some examples of planning goals. You might want medical information available across the continuum of care. So you want to make sure that the medications that the patient will continue to take post-discharge from the hospital are actually communicated to the practices, communicated to the patient, that you have the up-to-date data, the accurate data, the right doses of the medicine, for example. The various disciplines that need to have this information need to have access to it. And then an example might be data query. So for many years as nurses, we've been putting data into the system and we don't seem to get it out. So that's why I think early on the systems were disappointing to us, because we didn't know if we were helping patients or not. We were putting things in and not getting them out. Finally, now we're able to get out things in terms of reports, in terms of dashboards. Do you have any kind of dashboards that you use in your practice? What's a sample of a dashboard?
We use a dashboard for our provider, their metrics, you know, quality metrics that we have on dashboard. We do reporting for them.
And who has access to that?
Well, right now it's the provider practices.
Okay.
That we're working with. They have their own issue with them.
Sorry, Vanna. Sorry, Vanna, we didn't get you up there in time. Any other examples, since Vanna is standing with the microphone ready, to talk about dashboards? So dashboards allow anyone who needs that information to have access to it. And again, early days, only Mahogany Row would have access to the dashboards. The Paul Merriwell people. Then there is. Only Paul people would have access to the dashboards. We're talking about you. And now other people that need to know that information now have access. Fine. Hallelujah. So then we have to think about what are priorities. Well, patient safety might be a priority, or meaningful use might be a priority, or engaging customers. That might be our priorities. So we have to figure out what the priorities are. And meaningful use, that That's when the providers need to show they are using a certified electronic health record technology in ways that can be measured significantly in quality and quantity. So these might be some of our objectives, that we do want to reduce errors. We do want to have the data available to anyone who needs that. You know, if the patient's in getting a CAT scan done, do other people have access to that data? We have reminders and alerts, and that's the beginnings of a clinical support system. I don't think yet we have artificial intelligence in healthcare, just by people saying, oh, Watson's going to be there to save the day. The IBM product, I don't see that yet. So our objective may be what we have e-prescribing automation. Okay, so there's plenty of tools to help us. Things like surveys or other analytic tools. Tools that help us with gap analysis, spreadsheets. These are all tools we might use in planning. We might do a market survey and say, okay, we want to get, now you already have this, but let's say we want to get secure texting, or maybe we want to get evidence-based literature for our patients. And we want to see what's out there in the market. What do the other organizations have? What does Vanderbilt have down the street? What does St. Jude have? Whatever is appropriate. You look at the literature, you do internet searches, you talk to people that have gone to conferences, you may go to trade shows, you may send out a request for information saying, this is my need, please send me information. We're looking at a system. And then the feasibility analysis is looking at the technical feasibility. So if you need wireless access points in your ceiling, do you have those, or is it something that you can get readily? So you look at the economic feasibility, operational feasibility. What are the requirements? Is it some kind of system that one person can implement? Do you need a whole team of people? Do you need a team of people from all organizations? Do you need a multidisciplinary team? And again, what is the gap analysis? And that's a formal study to compare the actual and potential differences between the business requirements and the current capability. So again, maybe now you call the patients. We heard that earlier. You physically call the patients. Maybe you want a reminder, like the robocalls, I call them. Also under planning, a lot of this has to happen early on. IT projects will have guidelines or templates to conduct the requirements or user analysis. So remember I said I wasn't going to give the person from Vanderbilt a price because I didn't know what her requirements are. We had not yet interviewed her to find out what she needed. You also look at what the competition is doing. Sometimes you want to have, be competitive in that way. And I happen to be, I'm thinking of a Little Rock example. Michelle, you're from kind of that area. Are you from that area too, Paul? Little Rock? Okay. I sat on an airplane with a gentleman who was repairing CAT scans, and he was all excited. There were 2 new CAT scans for his company, and he was going to implement one in Little Rock, Arkansas. And I thought, of all the places in the U.S., that was the one that was getting, and St. Jude was the other one, getting the most up-to-date CAT scans in the world. And shoes. My grandfather was on the board of a hospital in Mountain Home, Arkansas, so I can say those things. They do have shoes in Arkansas. All right. That is so bad. All right. You need some kind of project scope document to address how big is this project going to be, and then people need to sign it. So you know if you're building the 10-story building or the 15-story building. Then somewhere along the line, you may make a go or no-go decision. In the example I told you that was at the School of Nursing, we decided not to go ahead with the total project because it would take too much money, too much time. We didn't have that. We just had a limited budget. So we just carved off a piece of the project, made it a smaller scope, and went with that. Okay. I sort of talked about market and user research. Oh, these are people that might be on the team. Somebody who does, they don't necessarily have to be in healthcare, can see what is out there in the market, what are the products. So if you're implementing evidence-based documentation in the ambulatory care, what are the products that are out there, who uses them, and someone other than a subject matter expert can look at that. But also we need SMEs, subject matter expert, and that's an arena where a lot of you can come in because you know your work environment. You know the work to be done. You know how it could be done better. And so often system subject matter experts are called upon for their expertise. Some nurses work as systems analysts to analyze the environment, figure out how we can apply healthcare information technology. We can author some of these documents. The word artifacts here just means like a thing, a document. So maybe we gather up all the current documents that are being used and try to figure out, well, how can we automate this? Should we automate it? Not everything needs to be automated. Automated is not the answer for everything, unfortunately. I wish it was. Wish it was. But, you know, it's a combination. People, process, money, tools, et cetera, et cetera. Interoperability. We need people to respond to and to write requests for information or a request for proposal. The request for proposal is usually a little bit more sophisticated, a little bit more serious. You're starting to ask the technical requirements as well as the financial requirements. Okay, and then you look at a feasibility study and say, okay, is it technically feasible? Can we do this? Can we just add on to what we have already? Does it meet the user's need? What is the economic feasibility? Do we need time from a systems analyst? How much is it going to cost us in terms of employees? How much does it cost us for training to take people away from their environment and educate them? What's the cost of any hardware we have to buy? What's the cost of any software we buy or develop? And then you think of the operational feasibility. Will this system actually work when you put it into use? Will the system actually be used? Just like I told you, there's situations where we may have the software and the hardware and they're not used. Some organizations, and these are generally for the bigger projects, have a project charter where you have a champion, you have someone at a high level saying, I support this strongly. So high-level management support is always needed for these projects. What are the dates of the project? When do you expect it to be completed? Let's see. What is the problem? Why are you doing? What is the situation that causes you to think that there can be an IT solution? What's the problem? The opportunity? What is the objective of this system? Who are the stakeholders? And the list might be even longer than this one. But who's involved? It might be people from medical records. It might be people from finance. And what is the scope of the project? So this was a little project. Let's just automate blood pressure, pulse, and temperature and have it integrate with equipment. Let's put it that way. What are the benefits and what is the budget? So that could be a project charter. And then also under planning, I mentioned request for information as opposed to a request for proposal. So the information may just say, I'm interested in finding out who has a product that would meet my need. Let me know if you have this product, and you might get something back that's just a few pages. Whereas a request for proposal can be very complex. For a period of time I worked for IBM, and I was in charge of proposals in the healthcare environment from the IBM side of life. So I was responsible for bringing together that would answer the questions on the functionality and the technical aspect and the cost and the hardware and software involved, et cetera, et cetera. I am pretty proud of that job because when I left, they hired 2 people to replace me. Yes. Okay. So let's see. Then, when you have a request for proposal, you probably have some kind of scoring methodology, and say what's more important. Is cost more important than the functionality? You probably also include scenarios, and I would venture to say when the team, when people pick the Epic system or the Allscripts system, you probably had scenarios and said, here, Mr. Vendor, take our patient through this scenario and show me how you do it in your system. I know you must have had reference calls or site visits. The vendor would tell you which are their best references, and then you might also find others that maybe are not on their top 3 list, and actually do a site visit. And then somebody has to write up a summary of recommendations, and then these need to be presented at whatever project team you need to present this at. Okay, so a typical implementation structure might include a steering committee. So you have higher level people that are committed, top level management support, some kind of data governance committee, an IT steering committee, probably a physician advisory committee. Then I would, of course, add things like clinician advisory committee, nursing advisory committee. Let's see, so you could have a build team. I know even though some of the products, like even with Epic, there's certain parameters that had to be put in to make it appropriate to your facilities. You can't just take it out of the box and put it in. It's, you know, if it could only be as easy as apps that we have on our phone, we're not at that point yet. You just can't download Epic. Let's put in a few parameters and then go with it. Doesn't work that way yet. So let's see, you probably have a testing team because believe it or not, the software we get does not always work perfectly. Even though the vendors try to test it and beat it up before we get it, maybe we've implemented in such a way that it's different from how they envisioned it, and so the software needs to be tested. We might have a change management or communication team. So even though we put a lot of thought into planning and implementing a system, maybe by the time we implement it, we find out, oh, there's a new meaningful use. Stage 3 came out, and we have new requirements. Or there's a new statewide requirement that we have to comply with. You have a training team, a support team. These are typical committees that are gathered together to implement or to plan, actually. Now we can talk about the next phase, the analysis phase, and that's the study of current practices and definition of user requirements for new applications. And the key objectives are here. We want to outline the user requirements, data flows, processes, and workflows, outline detailed system specifications, and conduct a market analysis. Okay. So during the systems development, the analysis phase, we want to understand and prioritize the gaps and the needs. We always have to think about priorities. We can't always get everything we wanted. We need to understand and diagram the workflows, the data flows, and the processes. And we may be diagramming what happens now, but then we need to think about, okay, let's do some fall cleaning. Since we just had fall yesterday, we'll think about fall cleaning and decide how can we do things better. We don't want to emulate the way we do it now. Maybe it's a manual way, maybe it's an automated way, maybe there's a better way. So we have to think about what are new workflows. We might want to create new processes. So we have to document the functional and technical specifications and outline the anticipated impact of the new system on existing processes and outline future state workflows, design flows, and processes. So that's if we're like developing. The right side is more if we're implementing. Again, thinking about what are the gaps, doing the market survey, and some of the things that are listed here. Oh, assessing organizational readiness for change. That's big. That should be on a slide all unto itself, because people don't like to change. How about that? What, the only change people like is that which jingles in their pockets? Or something about the baby liking change of the diapers. But no one really likes change. So some researchers, for example, Nancy Lorenzi and Robert Riley, who are at Vanderbilt, Nancy has a vice chancellor title. She is very concerned with organizational readiness and change management, and she says we cannot successfully implement anything unless we get a handle on this change. So that's why, when I was talking about models and mentioned Cotter, for example, that was used here in 2007, we have to think about the change and how do we move people from one state to another. Move people that don't want to move people that think they're doing a great job now, people that are getting ready to retire. There's so many reasons not to change, and we have to get a handle on this change. Have you, let's see, you've utilized Cotter, but can you give an example of successful change? Now, when Epic came along a few years ago, I'm sure people didn't say, you're going to use it and you're going to be happy about it. Was there any more gentle way to get people to use the new system? People were probably, okay, the system, what is the system people like the most? The last system they had before it was changed. So you may be crabbing about the all-script system now, but if it gets replaced, all of a sudden you're going to be remembering how wonderful the all-script system was, because we don't like to change. So any thoughts on change?
The more you bring the users into the preparation, the better off.
Yes, and that is a big reason why we involve users, to get them involved in the change, to understand the reasons for the change.
When we did Epic, we had what was called validation sessions. And for all the different areas that we built within Epic, we had these mammoth sessions where people from all different facilities were invited and went down the workflow, basically went through the workflow for everything. And they all talked, and then they agreed upon how it was going to be built. So validation, if they can be a part of that validation and feel like their input was there when the system was built, it would be more readily accepted.
Excellent. And I would venture to say, not even knowing the situation, I would bet there'd be some people that did not take advantage of that. And then they're like, why is the system like it is? I didn't have input. Yes, you did. Yes, you did. Okay. Thank you for that. So she's talking about the evaluation component after you make the change, making sure that your goals were met. Very good. Very good. Don't forget that part. So change.
We've used Cotter's, going back to Cotter. His first principle is create that burning platform. Because we've been working with physicians, enticing, may I use that term?
Sure.
Enticing them to embrace e-prescribing. Part of our, may I say, script, part of the words that we use as we work with providers is to say, now as you experience when you go for your own health care, see, kind of hook them in, you're accustomed in your personal health care to getting your prescriptions electronically. I'm certain that you want to do this for your patients. Stay tuned.
I go all over the country and I hear, like when we first implemented CPOE, I hear all the reasons why the physicians can't do it. I really think we need them numbered, like, oh, that's reason number 14. Oh, that's reason number 12. They're universal. I like physicians. That's okay.
I think our facilities too, we are a big health system and they're competitive. So if you can get that competitive nature, I know I was around when we first went live with Clinic, and if you can get your nurse managers on board, a lot of folks are like, no, I don't know anything about computers. And if you can work with them a little bit more on an individual basis and just try to lead them now we've got everybody, almost everybody over 75%. And I send out little messages saying, look at Indy and Pat, you know, look what you all have done. And then they start sending out, time to celebrate, you know, so I guess it's, maybe it's crazy, but it works.
Very good.
Just staying on top of it, don't
That-
letting it go to the, go down the wayside.
That's a good positive example. At Vanderbilt, they were implementing the patient portal, and these were in the days where we had to have like 5% of our patients actively using the portal. Now it's one patient, I think. I think we're going backwards. Anyway, 5% of the patients. So what they would do, instead of putting out the list, oh, I know, they wanted the physicians and the nurse practitioners to get back to the patients, I think it was like 48 hours within a short period of time, to answer questions through the patient portal. And people were not doing this. So rather than report the list of the negatives, the ones that weren't doing it, they reported the list of the positives and the ones that were successfully getting back within 48 hours. And so the other people wanted to be on that list too. Oh, I want to be on that list. I want to be on the good list. How do I get there? So whatever method is utilized. Okay, so if we're developing a system, you talk to the stakeholders, you do interviews, you might do a focus group. You probably, when selecting carts, for example, mobile carts for medication administration, probably did a focus group of nurses to see which carts did you like best, which worked. And then observe people in the workplace, because sometimes we say things, oh yeah, it takes me 10 minutes to do that job. And then you find out if someone observes you, oh, maybe it's really 12 minutes or 15 or 20 minutes. So it might be a combination of interviewing people plus a workplace observation. The artifact analysis is looking at what documents do we have now, what requisitions do we have, what clinical documentation do we have, what communication methods, what forms go where, and what do we want to do with that. We may diagram it, and there's different methods to diagram our workflow. We might diagram the data. What data element do we need? Where do we get it from? Where do we send it to? What form is it on? There is something called a business analysis book of knowledge. This is a good resource for systems development as well. I talked about some of the items on the right side. Some of this is redundant. Okay, more on analysis. And then we have to report out what were the results of these interviews with the stakeholders, what are the requirements, what are the regulatory requirements, the ones that we have now, the ones that we expect to have. You know, we're all like waiting for Meaningful Use 3. We have an idea of what that's going to be. We don't know yet, but we have to be ready for that. What's the current and future state diagrams? So what are we doing now? What do we want to be doing? Let's see. What can I talk about that's new? In implementing, again, we have the readiness assessment. Is this organization ready to go live? I worked at an organization where it was a major organization. We implemented in 2 facilities and then did kind of a cursory evaluation, because to me, we would have done a real thorough evaluation on those 2 sites, because one was deemed really good implementation. The other one was like really bad implementation. Well, we needed to look at those factors and decide, okay, do we need more education? Do we need more equipment? Better workflows? Do we have to re-examine our policies and procedures? What do we really need to do? And then they quickly went on and implemented 20 more sites. And all in all, they got implemented. But I remember, too, one of my jobs was, one of the things that was done probably not in the best way was we were implementing CPOE, the computerized provider order entry. This was in the hospitals mostly, well, it was everywhere, but also on the hospital side. And after implementing, then they decided, well, wait a minute, we need a way to notify the nurses that we have new orders or new procedures. We're just figuring this out now. We probably didn't go through the systems analysis phase, because this should have been done way early. So at the last minute, they're out there buying 42-inch monitors, big monitors, smaller than that, but big monitors to put in the nurse's station with the de-identified patients, and then these icons that meant X-ray or new medication or new procedure. like, this is kind of backwards, so we really weren't ready. We weren't ready and could have done a better assessment. Okay, and here's some skills. So again, we're talking about we need experts in the subject. When implementing, we need a project manager. The project manager might come from a clinical background, maybe not. So all sorts of skills are needed. This is just an example, perhaps, of diagramming on the left side the current process. And it may have X amount of steps, and then on the right side is the new process. So it doesn't even matter what's in there in the little print. It's just that this is a way to say what's the current, what is the future state. So this is just happens to be an example of that. Let's see. Okay, so moving on to the design and development stage. This is a blueprint of the new planned systems. It's derived from the design phase, so you have to have the design phase to go on to this phase. Let's see. In this phase, the user requirements are translated into new software solutions. Vendor tools are customized to meet the end user needs. And again, we usually don't take things out of the box. I mean, some of the products we do, things like the Microsoft products, yes, we take those out of the box and use them. But practically everything else we use in the healthcare environment has to be customized to some extent. Let's see, if you're writing the system within your organization, you need development teams to actually write the code. These are like usually programmers. Sometimes nurses and other clinicians like doing this. Generally, we have other people do it. We test the usability of the product. So usability would be things like looking at ADA, the Americans with Disability Act, making sure people that have vision problems can see the letters, making sure that people that are colorblind can see the screens. So those would be some examples of usability. Usability is so important. Through another organization I didn't mention, AMIA, American Medical Informatics Association, there is a group of physicians that are members of this organization. They have a blog that people talk, or email list, I should say, that people talk about lately, and it's mostly physicians that are complaining about the usability or lack thereof of the information systems. So they have to use them with meaningful use, et cetera, but they're usually complaining about them. And in some cases, I can understand why. All right, so then if you're on the development side, the stakeholders have to review the development to make sure that what is built matches the original vision and scope. I was on a project, this was pretty exciting. I worked for a vendor. The vendor was taking a product, it happened to be called NextGen, which is used in some ambulatory care practices. And it was a good product. We had to tailor it to meet the needs of the U.S. government because this product was going to go into all the consulates and embassies around the world. That was pretty darn exciting. So I was working with the technical people, and they were doing things like in metric, and at the time we were doing things not in metric. Now I know organizations are going more metric. Are you guys going metric with input of weights, for example? Do you do it in metric or do you do it?
Our software converts. You can put it in one way and convert it.
Okay. So what's the end point? What's the goal? To be metric or?
Metrics for the physicians, especially on children.
Okay. So even that little change can be upsetting, and you have to prepare for that and be ready for that. Let's see. So usability testing is good, making sure that what we build matches the original scope and vision. We use tools, and I've said this before, they don't come out of the box ready to use, unfortunately. Often we have to customize, but sometimes too, We don't want too much customization for one reason, that it's harder to apply new updates. That's one reason. When I go around the country, and even like the first nursing unit I worked at, I was a head nurse on one unit. Hospitals, organizations think they're different, and so they have to implement it in a different way, or they have to have a different system, or they have to be more customized because they think they're special. So, you know, I hear that a lot at Vanderbilt. Well, we have to have this customized product because we're special. Or somebody like St. Jude might say, well, we have to do this because we're special. Yeah, we're all special. Get over it. We have to implement systems somehow. So we might have to bend a little and not have a system that's as customized as we would like it to be. Or I think that Vanderbilt people are going to have trouble because they have a highly customized system, a system that was developed to meet their exact needs over a number of years. And now when they implement the more out-of-the-box Epic, I think there's going to be a little bit of tears, blood, sweat, and tears. That's my prediction. But they use the system development life cycle, so they'll just have to get over it. So end user input and engagement is extremely important in this phase, as all phases. So if you're developing a system, you take the outputs of the design phase, and this becomes the blueprint for developing the system. There's various tools for developing software. If you're implementing, again, this dictates the system configuration aspect. You need to have a project manager to keep the project on time, in scope, within budget. That's often hard to do, very hard to do, but a nice goal. Okay, more on design. You think about things like the software code and who owns the code. Can you get access to the code? Some organizations, you have the code in escrow, so if the vendor would go out of business, then you could have access to the details behind the software. Epic, I don't think you do. I don't think you have access to the code. That's their proprietary information. Okay, so if you're designing a system, you might have a product prototype. So you would go to the users, like when I was on this next gen project, and the designers came to us and said, well, how do you like the system? We would say, well, we're not using metric. You know, we can't use that now. Or they would use like the British spelling because the programmers were from, happened to be India, and we were using the American spelling. So it's like, glad you're showing this to us now so we can make some early changes. Let's see, if you're implementing a system, there's technical things like what is the database that holds all this information together? Where all this information, where does it go? Where does it go? Sometimes organizations will have a central repository, a physical repository. Sometimes they will send them to the vendor. For example, there was a company called Shared Medical Systems where everything was mostly housed in Malvern, Pennsylvania. Now things are housed often in the cloud. In the cloud. Have you heard that? Cloud computing in the cloud. We've got lots of clouds today. So you look outside and you say, well, that might be where my data is. That's not really the definition of the cloud. The cloud really is a server. You've heard of a server, that's a computer. A server, and you may not physically know where it is, but that's where your data is. So if you happen to have Apple products, you probably have your pictures on the cloud. So you don't know if they're in Tennessee or if they're in Alaska. You're not sure where they are, but you can have access to them through the internet. We also have to think about a data dictionary, so that explains the terms in our database. And that could include things like gender. What are the terms that you use for gender? And we hope there's some commonality. And apparently there's a number of different terms just for gender, so we have to agree on what terms are we using. And actually, in recent, those terms have changed too. We're looking at documentation forms, either hard copy forms, forms that are on the computer. What are our flow sheets looking like? Sometimes organizations, sometimes nurses will think, okay, we have this flow sheet, we've worked on this flow sheet to track vitals for years, we've improved it over the years, we really like it, we use it every day. We want to take this flow sheet and put this exact same thing on the computer. And then you may find, well, maybe that doesn't optimize the use of the computer. Maybe it's hard to find things. Maybe your spreadsheet now is 11 by 17, and you can't quite do that on one computer screen. It might be like too small to see. So these are some of the things we have to think about. What about security? Security profiles could mean that in some organizations, maybe each person has a different profile of what they have access to. Or maybe categories of nurses, categories of employees have access to certain items. So maybe the ambulatory practice nurses have access to who knows what, maybe only their patients. Maybe they have access to all the patients because you might get those patients someday, who knows. But these are things that have to be decided ahead of time in the design phase. And then you look at process redesign. Are we going to do the same old thing we've been doing, or do we need to use this as a time to re-look at what we're doing? Change management is important. I've mentioned that several times. We need project managers to track what we're doing. There are certifications in project management. Sometimes people do project management. You probably all have done some kind of project management without schooling on how to do it, maybe the School of Hard Knocks. But there are certifications for project management. PMP is one. Maybe you've seen that behind letters behind people's names. And of course, we need approval along the way from the clinicians. We just don't want these to be IT projects. We need their help, but it should be our projects. Let's see, we have to be clear on the competencies needed for design, and competencies really are just the ability to do something successfully. We need skilled teams in place for development and implementation. These are some of the people that might be on your team. I have seen more titles these days like change manager or transition management as titles. So I've seen people that have change as part of their title. All right, these are some of the skills that are needed in the design phase, or some of the things that we're trying to display the patient data so we can make clinical decisions. And as I mentioned before, I think it's through meaningful use, we finally have the data, we're putting it together in meaningful ways, making information. And that's part of the definition of nursing informatics, where we take data, put it together in meaningful ways, making information, creating nursing knowledge, and going toward wisdom. That's our continuum. So we finally are starting to see that we have data to make decisions. We're doing more than just our gut feeling. We can put the data together in meaningful ways and come up with reports and trends that we've never seen before. We can start looking at medications that are given and saying, okay, this medication is supposed to help the patient's blood pressure go down. Is it working? Part of what we do in this phase is we translate the user requirements into informatics solutions to support our workflow and clinical practice. So we're incorporating aspects of the nursing process or other processes. We can customize data elements using the tools that the vendors give us. We can optimize existing systems and applications. One of my colleagues was hired. This was a Meditech shop. That's another major vendor. They were hired to look at what aspects of the system that they had purchased but were not utilizing that would help patient care. We can make recommendations for programming changes. So you're starting to see how we can, I'm encouraging you to be proactive and have input and have a vote. And why? Do this all for the betterment of patient care, help to optimize patient care. Here's some thoughts about database. A database could be something like a list of your area pharmacies. You know, when you say to the patient, what is your local pharmacy? You need to have that list already input somewhere. So a database is a tool for information storage and retrieval. Many end-user applications, such as electronic health records, incorporate a database. So there's different kinds of databases, something called a hierarchical database or a relational database. So these are generations of databases. The relational is supposed to be a little bit better. We use a query to retrieve data from a database. So if you want to find out which patients in your practice need to get their PPT done so you can send them a letter, you go into the database. You may not know you're going to the database, but you use a query to get information from the database. And I used to think just because something is on a computer, that meant it was correct. And maybe not. You know, I used to think because it's printed on that green and white paper, that it has to be correct. And the data is only as good as what we input and how it's input. It may be input by hand, manually. It may be input automated from maybe automated blood pressure equipment. It may be input from a link to other databases. So we have to think about whether or not the data is good data. All right, so there's different kinds of databases, a logical database, a physical database. What can I say about this? Here we talk about things like, well, unique identifiers. In the olden days, we could use the Social Security number, and we can't do that. So what do you use now as a unique identifier for your patient? What is the number that uniquely identifies that patient? Okay, so you call it a medical record number? Okay. And it used to be Social Security, but probably not anymore for a number of reasons. One is we found out that there are duplicates in Social Security numbers. All right, I don't want to be too technical, but here we talk about things like discrete data. So nurses and clinicians are famous for wanting to, we want to tell the patient's story because we want to put in a narrative note. And that's what we're used to doing from the past. We're used to writing a narrative, patient, hopefully more than this, but patient ate well, slept well, had a good evening. Wife in at 3 p.m., girlfriend in at 8, whatever. But we can't do that any longer. We have to have the data in such a way as we can capture it and then report it back for whatever is needed. So we can't put, here's a better example than what I just gave. We can't just put in patient, alert and oriented, blood pressure, whatever. Some of these have to go into discrete fields so we can pull it out and make reports and then start looking at things. Was the patient's blood pressure improved as a result of our intervention? All right, so we have other tools such as a PERT chart. I've used this. I haven't really seen a lot of it recently, but these are just tools to help us diagram. In this case, it would be activities. So this happens to be a PERT diagram for the analysis phase of a systems project. It's a management tool. It stands for Program Evaluation and Review Technique. It shows the things that have to happen before other things. The next slide actually shows you a picture. Okay, so it shows you what has to happen. So the things on the very left-hand side have to happen first. There's some things that can happen together. Like perhaps before you install software, you have to have the hardware. But there's things that can happen together. Maybe you can install the hardware, the terminals on the nursing units, plus you can install the wireless access points at the same time. And then the critical path identifies the shortest time to complete the project. So this is a tool, what's in the circles might be like the days it takes to complete the project. So in this case, the straight line across would be the shortest time to complete the project. So it's not like you can't produce a baby in 1 month by having 9 fathers. Somebody laugh, please. Besides me. All right, more tools. You've probably seen a Gantt chart. This is a good way to display for your colleagues, for your managers. What's going on? Are you ahead of time? Are you behind time? Which tasks are lagging? It can also be called a work breakdown structure. There's a Microsoft Project is a tool that a lot of people use for project management. You can have them very simple, you can have them very complex. But this, at a glance, can show you this key happens to be what activities are incomplete. So all the green ones to the right are incomplete. The red ones to the left, or orange, whatever color that is, are completed. And then the ones with 2 colors are partially completed. So this is a good way to show your team or your managers what needs to be done. So that's often used in this process. Okay, I mentioned this already, that we have to think of our users that do have low vision, do have some kind of cognitive impairment, maybe temporary or permanent problem with mobility or dexterity, communication, are they deaf? And this goes along with the Americans with Disability Act. We think of this too when we develop websites, actually. All right, then testing. Testing, I think, is a fun time. I like the testing. I was good at that. So if it, I was good at well, when I worked in the IT department, they would be like, Susan, nobody ever does that. That's not how we intended the system to work. And I would say, yeah, but that's how I happen to think I was supposed to be using the system, and maybe other nurses would do that too. So just because an analyst would design it thinking you have to do step 1 and step 2 and step 3, a nurse may come along and do something different, or select the wrong key. I clearly remember testing, and we had you need to have different environments, a testing environment versus a live environment, and then maybe even a training environment. So at least 3 environments you need. Here's a couple stories. When I was working at St. Agnes in Baltimore, somehow I was accidentally tested on the live environment, which you have to do eventually. But I was doing that, and so the techie people were like yanking my chain and telling me that they were going to charge me for that ICU patient I put in the beds and gave tests to. They were just kidding me. That wasn't really going to happen. What else? Another testing. I'm trying to think of other testing stories. Well, this doesn't apply to healthcare IT, but kind of the same concept. One of the kinds of testing would be load and volume testing. So I was doing a boot camp, this 2-day course I call the Nursing Informatics Boot Camp, and I was doing it in St. Paul, Minnesota, where they just had a new hockey stadium installed, and so they hired people to simultaneously flush the toilets. And they found out actually that there were problems. So they were emulating what would happen during halftime or whatever they have at hockey things. Period. End of the period. That's it. I know something. Okay, so at the end of the period, everybody goes to the bathroom, so they wanted to emulate. And actually there were problems. There was flooding on the carpets. They had to pull the carpet up, revamp, et cetera, et cetera. So there's a reason why we do testing. So we're answering questions like, does the system work? Are the interfaces valid? So if we have information that's moving from the lab system to our electronic medical record, does that come over properly? Is it ready for use? Is the system easy to navigate? Does it have the appropriate language? Is it effective to use and intuitive? So we have to do some system usability testing as well. And let's see. So here are some of the things that we test. Testing, again, if we have a vendor product, the vendor would have tested the systems, but then there's always bugs and things, maybe in how we use the system, maybe in how we install the system, that need to be tested again once installed. So we test prior to implementation. That decreases the chance that we've missed something. The goal is to use this testing period to validate that the components work as intended and to make sure that interfaces, components, functionality will hold up in the live environment, making sure the new processes do not allow for privacy and security breaches. I remember at a different hospital in Baltimore, I was in charge of the database for a 700 physician practice. And we had, don't do it this way. We had a training database. When people would go train for the system, they would say, or we would ask them to register themselves. They would say, well, wait a minute, I'm already in here. What? They had just come for training. Somebody decided in their wisdom to copy over the live database and make that the training database. Not a good thing. Yes, I hear by the gasps. Not a good thing. Because there's all that private information that you don't want people to see. Now, it was probably about HIPAA time that this started. So that was like a big no-no. But I have worked in an environment recently where they didn't even have a training, a test, an environment, I should say. They only had one environment. They did not want to have a separate environment for training and a separate one for testing. And I really had to put my foot down at that, because you want to test in more of a safe environment, make sure you work the bugs out before it goes to a real life environment. And I think about the time I left that job was when I started seeing test data merge over from the test environment to the real life environment. And the way I found it out was I used, of course, my dogs as children. I don't have two-legged kids, as I mentioned. So I used my dogs, and when the dogs started getting in the real life environment, I'm like, I'm out of here. This is not a good situation. Okay, so here's all the elements that we test. We test the components of the system, the features, the functionalities, the interfaces between the systems, the devices. We test out the hardware as well. We test out the reports, the screens. Reports, you have to think about not just the daily reports, but the quarterly reports or the 6-month reports or the yearly reports, and then test out user access and security and make sure it's appropriate. Make sure if the physician needs to have access to all patients, then he or her does have access to all patients. All right, thinking about testing tools, I've mentioned this already. These are the types, we call them environments, that are set up. So you might have one for the people that develop the system, build the system, one for the testers, one for the trainers, and then the live system. There's different types of testing. This is actually only a brief list. There's many, many types. I think, alpha beta testing. Alpha is like testing generally by the vendor within the vendor's home. Beta testing might be the first one that has access to that software. So when I mentioned my colleague in Maryland, she was beta testing a product. They were the first people to use it. So they were testing it in real life situations. That's the beta. Scenario could be you have a scenario that says, okay, this patient was admitted to the hospital and they were discharged, then they went to this physician practice, they got this medicines, they had these procedures, they had these appointments, and hand them a script and say, follow this. Does this work in your system? Do the appointments carry over? Does the patient name carry over? Is it the right patient address, et cetera, et cetera? Unit testing is testing within modules. Integration tests across the modules. Load volume, I already talked about with the flushing, but also too, it seems like everybody in the hospital or in the healthcare environment works on Wednesday. So you might want to test on Wednesday when most users are using the system, for example. Regression testing, I think this is my favorite kind of testing because sometimes when new software is applied, something breaks, something else breaks. And we probably know this, like with installing Microsoft products, for example, or iOS in the Apple. You may install something new, but something else, there's a problem with something else. And so that's the regression testing. We have to test the old things as well as the new things, make sure we didn't mess anything up. And there are facilities that use automated test scripts. So instead of having all of us in a room, admitting a patient at the same time, making sure we're testing the load and volume, we can get automated testing algorithms that do this. Instead of having 50 people, we might only have one person doing it. And then we have test outputs. What were the results of your tests? I've talked about this kind of testing already. Nurses and others might be involved in testing scripts, validation of data across the system, which is integration testing, end user acceptance, system performance, and generally resolving unanswered problems and questions. Sometimes people put it in their contract that they're not going to pay for a system until it's tested and accepted by the user. Yay. Anybody still hot in here? I think of this girl wearing a sweater. She's wearing her fall sweater. Okay, but she's happy because they're getting ready to implement. Yay! So the implementation then is the deployment or execution of the information system for the end users. And then after you implement, evaluation, maintenance, and support are ongoing. So again, you can't, just like I thought naively, you can implement and then you go do something else, have a nice life. No, it's an ongoing thing. All right, so when a system is live, you might call it a go live. Don't Google that because you come up with weird stuff that you may not want to come up with. It is a cultural change. A go live, the date or dates that you start a new system, it will impact the clinical workflow and the policies. You may want to have extra people on duty when you do this. Let's see, you look at the end user acceptance, you look at the system performance. So maybe you didn't quite test the load and volume and you find out on implementation day that maybe you need more servers or better networks or something. Maybe there's compromises with the performance. Once you buy a system, they have to be maintained. There's always upgrades. Your organization may say, okay, we're going to only upgrade every 3 months, every 6 months. You may not want to upset the users, so you may just want to time those upgrades, time them where it may be least obtrusive to the organization, the least negative impact. You need people to look at the security and the performance and support the end user needs and address the end user problem. I think I talk about this later, but you need people to be there, super users. Do you have super users? Okay. Probably all super users. But people that may be one step ahead of you that can help you with problems. There's different ways to implement. Sometimes people use a pilot, so they may go live on in one practice, and then work out the bugs, so to speak, and then go implement in other practices. Or phased could be maybe we want these units to go first, and these units will go later. Or big bang, that means it's like tearing off the Band-Aid, like rip it off. Let's have everybody the same day start the new system. So do you remember, what did you do, those that have Epic or have implemented recently? Which kind of implementation did you use? Big Bang. Let's just do it all at once. And there's many advantages to that. If you're doing phased, for example, you may have some practices that are not on the new system, some that are on the new system. It may be a problem with sharing data, for example. So it seems like more and more people are going Big Bang these days. Parallel systems could be the old and the new simultaneously. People don't often like that because it was used when we went from manual to automated, and so you would have to do double duty really, and you may have to input the data twice manually as well as automated. So kind of going away from that. Data conversion, that's a strategy. So since you have had recent experience going from McKesson to Epic, decisions have to be made. How much data are you going to keep? And I know one of my, I have a friend who had horrible chronic problems with every body system, I think starting from Legionnaire's disease. And so he was in the hospital a lot for the last maybe 4 years. He was probably in the hospital or some kind of environment fully half the time. Different environments. He went from acute hospital, rehab. He had double lung transplant, kidney transplant. So he had a lot of health care. And luckily he was married to a nurse, so that she was essentially his care manager, I think. But so fully half the time was spent in healthcare. One time I went to visit, and he had an episode, had to be transferred to the local hospital. And he had been seen at the other hospitals in this chain of hospitals many, many times. But since they started Epic, they wiped out all the previous information. So nothing could be pulled up. He had to be registered again. Everything was new. And I was just a little bit surprised because of the tremendous history he had in the healthcare system, and it was all kind of lost. I mean, it wasn't lost. It's available there somewhere, probably a little bit hard to get. So these...
What we did was a cardiologist won next gen. So we converted all their data into DataArc, which is an archiving system. And then we put a link within Epic to that archiving system. And then our other practices want all scripts, so we put all that information into DataArc, and then the link into DataArc so that you get to it. And then our McKesson system just had too much data in it. So what we did was, again, we put a link within Epic to McKesson. So all that information is accessible to the physician, so all that history is there.
Oh, hooray, hooray for that. But think of the decisions that had to be made because of this practice on that system and that practice on that system. This takes a lot of work and thinking and planning, and that's why we use a process such as the systems lifecycle. So it's good to have a communication plan, you know, for like example, well, I'll talk about it later, downtime. What do you do in case of planned downtime, unplanned downtime? For unplanned downtime, how do you decide, you know, how long do you stay down before you start resorting to maybe manual practices? And you must have policies for that within your organization. And then speaking of downtime, who puts the data back into the system afterward? You know, does your practice do it? Does somebody from medical records do it? Do you put in minimal information? Do you put in full information? All of these decisions have to be made. So these are all types of plans and workflows that have to be considered during the implementation phase. Broadly announced to all the people that are involved. Let's see, these are some of the knowledge and skills that are needed. We already talked about implementation strategy. Let's see. Once a system is implemented, you may, translation, you will have issues. So somehow these need to be logged and managed. So this might be a person at the help desk that triages the issues, logs them, assigns them to people to be rectified, and then managing what happens to that issue. So it may be something very simple, like someone having trouble signing on. It may be something much more complex. Okay, along the way we have to assess ongoing training needs. Sometimes we forget. We may decide, okay, let's train the people that are here today. Well, what about the students? How do they get trained? Do we have medical residents? How do they get trained? What about new people? Are they trained in orientation? Let's see, we need to plan for contingency. You will have some kind of downtime, whether it be scheduled or unscheduled. You might have a scheduled downtime when you get an upgrade of a system. That would be an example. And along the way, we need to think of policies and procedures. They need to be written. How do we handle downtime, for example, would be one of the examples. What about downtime forms? Sometimes organizations have little downtime, and then when they do have it, then they're like, well, where are the forms? Oh, our forms are outdated. Our forms were for the McKesson system. Now we have the Epic system. What do we do at this time? To be an implementation manager, you need to be really a cheerleader, a strong leader, an excellent organizer. It would be good to have some clinical experience so you understand this very complex environment that we work in, and you have to be able to communicate as well as motivate. So these are just some of the skills. Okay, this may be your implementation team, those clinicians who are experts at what they do. You have to be able to match the skills with the tasks involved. If you have a super user, you don't want that to be somebody who just started within your organization last week. It has to be somebody who's been around a while. Consider a broad representation of users. And this broad representation could also include some of the people that are like the naysayers, some of the negative people. I was able to go to a veterans hospital in Tampa, and one of the people that was showing us around, I remember her name. She was an LPN. Her name was Bunny. How could you forget that? And so Bunny was telling us how she was one of the naysayers at the beginning. No, the system's not going to work. We're taking our time away from patient care, all the reasons why she didn't want to use the system. And then it turns out she became one of the biggest proponents of using the system. And in fact, she was showing us how they were using it. Yay! Yay for Bunny. All right, so when thinking about change management, we have to acknowledge these people that are the opinion leaders. We want people to be early adopters. I was talking about models and theories, and Everett Rogers has a model of adoption. So they talk about people that are like the innovators, and you want people that are the early adopters, maybe not the pioneers that get the arrows, but the ones that are willing to try new things. Involve users from the beginning, we've been mentioning that. Inform the users of the progress, and even if you have like setbacks, you may say, we were going to implement January 1st, but we have a little delay because there's a shortage of hardware, so we expect to implement January 5th, whatever. Let the users know the progress, respond to concerns, focus on the positive results, be patient, change takes time, and have some fun along the way. Did you do anything when you implement? Like, did you have a mascot or a party or free pizza? Can you think of anything you implemented that you've celebrated? Yay! Still celebrating. I like that attitude. We're still celebrating. Yeah, Michelle.
We deliver gifts to our early adopters. Like we went live with our inpatient provider documentation. We nominated what we call adoption heroes for each site that we went live with. And then
So your gifts, were there things like new Mercedes and stuff like that?
Not quite.
Okay. Well, that's a pretty good gift. Well, and some organizations, you know, they may be want to conserve monies and have things like an ice cream social, just something that recognizes the employees, because it does involve all of you. It does take time. It's a change from the normal status quo. So it's a time to have some fun and celebrate your successes. And you don't always have to wait till the end either. You can, you know, on an interim basis, you can say, okay, we got this phase done. Let's have a party. All right, so in thinking about education, depending on what product you buy, the vendor could help educate. Those of you that are on Epic, some of your people in your facilities may have gone to Epic Land to actually get training. Some of those trainers, certified trainers, may have come here and trained other people. Sometimes systems analysts are used. Sometimes facilities, especially those going big bang, might say, well, we don't have enough manpower within our organization. We'll either have people from vendors or we'll hire people to come in and train. One of my nurse colleagues actually started a consulting group where he is hiring residents and physicians to come in and be at the elbow with training other physicians, which I thought was quite clever, because you know how physicians like to be, I mean, nobody likes to think that they're behind or dumb or stupid or make mistakes, and so one-on-one may be a better environment in that case. You may have in-house trainers, other systems users, virtual classes, web classes, online classes. So here's just an example of a go live. You might have a command center, and I bet you have this kind of thing at your organizations for the bigger implementation. So you may have people on site. It may be 2 weeks. It may be such a big implementation that people are on site that can help you and help with any problems that might occur. Or if it's a smaller implementation, maybe they're just on site for the first day and then available by pager after that. The super users may be on site maybe 2 weeks or longer. Super users, I was telling Michelle, some organizations don't even believe in super users, and I'm like, how can you not believe in super users? So generally they're people from the unit, they have experience in the organization. Hopefully during the time of implementation, they do not have to do patient care. That would be a good thing. They're relieved of patient care, scheduled without a patient assignment, as I said. They may be doing like one shift for 2 weeks and then go back to their patient care. They may be doing things like completing chart audits to make sure that our systems are keeping up with what they're supposed to be doing. Let's see, so the super users may actually assist in the classroom and their support during the go live. So super users can be a valuable resource. Here are some other areas where we may need support. So the operational support could be planned and unplanned downtime, events and procedures, day-to-day system support. The technical side could be assessing the current hardware for adequacy. Are we archiving things properly? I know of an organization when I was at University of Maryland. Let's see, this was in the intensive care unit. They had a product that was used, well, it was called Apache, and I think maybe Cerner's bought that product now, but it looked at the patients that were in the intensive care unit and determined which patients could stay and which patients needed to move out, looking very objectively at the data. So this product was used, backed up faithfully every day for 6 months. There was a system crash, and they went to the backup to archive from the backup. There was no backup. They'd been backing up nothing for 6 months, and no one tested it out. So they elected to go back and by hand input the information from the last 6 months. Don't do that. That's why we have examples to show you how not to do it. You have to still think during this evaluation phase, the ongoing phase, about the social and cultural aspects. These are things like, are your champions still have the pom-poms and cheerleading for your new system? What about enhancements and upgrades? You're going to have them. Some of them maybe patches, as they're called, like immediate fixes. Some of them could be maybe nice to have upgrades. User support, think about the help desk. Usually organizations have a help desk. Is your help desk open 24 hours a day? Okay, good, that's a good thing. And they probably have something for escalation. So if the help desk person there cannot handle the problem, then they escalate it to someone else. Then evaluation. Remember I said sometimes we forget this part. Generally, it's good to develop some kind of metrics before implementation so you know, are you being successful? So you may look at the system in relationship to the strategic plan. Did we do what we expected to do? Did we avoid costs? Did we save costs? Do we have risk reduction? Are we having less lawsuits? Are we having less patient errors, medication errors? And so reducing costs, though, is not the only benefit of system implementation. So we may be meeting goals, we may be improving customer satisfaction. When we look at system maintenance, it includes system stability and steady growth. Training and documentation changes may be needed with each upgrade. So not only training documentation, but documentation as far as policies and procedures are concerned. So maybe we have a certain policy for medication administration or secure texting. If we implement a system or an upgrade, we will have to examine those policies and make sure that they keep pace with the new system. Integration testing is needed. Regression testing, remember, that's the kind of testing that, does something fall off? Does something not work because we have new software installed? And then we need to think that there's money involved in continuous upgrading. The vendors won't just say, okay, we'll give you the new version for free. There's usually money involved. Okay, so thinking of ongoing support, I mentioned several times that the modification and maintenance are never ending. We need to prepare for upgrades to the system. Even those of us that have Apple products, we see, it seems like every few days, upgrade is needed, and we need to apply those upgrades. For our client, which may be us, we need to think about the help desk. Sometimes you might have an end user group within your organization. Epic has user groups all over the place, so if you have questions that you cannot answer within your facility, maybe somebody else with a like system can answer those questions. We need to assess our training needs. Maybe we're getting to the point where we don't have to include, I think of riding on an airplane and they're always showing me how to apply the seatbelt. I always think, I know that. Now, when I started driving, we didn't have seatbelts, but I know now how to apply that. When are they going to take that out of the instructions on the airplane? I don't know. Maybe that's that one person that doesn't know how to apply their seatbelt. Okay, so we can do this ongoing assessment of training needs. Maybe we're using a mouse, and in 10 years from now, everybody will know how to use a mouse, so we don't have to teach people how to use it. And I remember the first person that taught me how to use a mouse, one of my friends, and she was telling me to double click, and I was like clicking once. Double click, double click. I remember screaming at me, double click! So I know how to double click my mouse thanks to that. But someday in the future, we may not be teaching people how to do that. Actually, who knows? We may not be using a mouse. When I started using health information systems, we used a light pen, which looked like a pen. I don't have a pen up here. It looked like a pen, and you would select items on the screen. Some of you have heard of this or maybe used this. We don't use that technology anymore, any longer. But that was the latest and greatest technology. All right, and follow-up education may be needed. Maybe there's some aspect of a system that we only use occasionally and need to have some follow-up education. All right, here's just some words. Boy, that's a lot of info in a short period of time. And by the way, you know that you can take whole courses on systems development life cycle, so what we've talked about in an hour is a lot. But these are some words of wisdom from the IOM, Institute of Medicine. In 2010, they say electronic health records can improve the quality and safety of health care. Well, that's what we believe, and that's what we have to work for and work toward. The adoption and effective use of healthcare information technology can help reduce medical errors and adverse events, enable better documentation and file organization, provide patients with information that assists their adherence to medication regimes and scheduled appointments, and assists doctors in tracking their treatment protocols. And I think this still holds true today, even though this was 2010. Speaking of, I talked about Bunny at the VA. When the Veterans Administration implemented barcode medication administration, they figured they immediately reduced their medication errors by half. Immediately. So that was a good thing. Okay, and I'll just skip this because, mostly, didn't remember what I was going to say on that. But now, let's talk. We have a little time. Any questions before we go on to the next section?